So I'll do my best, but Melanie Barwick is a senior scientist at the SickKids Research Institute. And I think we've known her at CCHCSP for a very long time. I think you probably started or were very early on in our KT workshop. And so really, I think originally had an interest in KT, which is how I met Melanie. She sort of gave me a training course when I was a fellow 10 years, 15 years ago, a long time ago. But now Melanie has moved on to bigger and better things in implementation science, which she'll explain what that is. And I think give us a great introduction on how important implementation science is for whatever type of clinical research that we're doing. And so with that, I'll keep it short so that Melanie can give us her talk.
Okay, thank you, Eric, and thank you, Linda, and we'll get going. I think Linda mentioned before everybody joined on that we'll just keep questions till the end, but feel free to write questions in the chat. Linda will moderate that. We'll leave some time for discussion at the end. And for those joining from Quebec, bienvenue. Je suis bien capable de répondre en français à toutes vos questions plus tard. So here we go. So I'm going to talk about implementation science today in the next hour and give you a bit of an overview of why it's important, distinguish dissemination and implementation. So just unpack that knowledge translation term we're so fond of in Canada. And then identify what I view and what others view as the core components of implementation. So thinking of core components, it's a huge field. It has grown tremendously in the last 15 years. If you start to do a deep dive in all the implementation science literature, it's really hard to unpack it, pay attention, and try and figure out what are the core components and what's important. So I'm going to do that for you. And then I'm also going to introduce you to the standards for reporting implementation research and to hybrid effectiveness designs, and then share with you, point you in the direction of some implementation resources. So quite a bit to do in the space of an hour. So knowledge translation, as you are all probably very familiar, is a process and a set of activities that we use when we want to move research evidence to those who can benefit from it. And what I'll point out in my definition, and what I like to point out as a distinction when I talk about knowledge translation, is the emphasis on benefit. So as you can see, I did not use the verb use. And knowledge translation really is about taking our research evidence and making it widely available, accessible in ways people can understand so that they might benefit from that research evidence. And sometimes that benefit is instrumental. So sometimes we are talking about changing practice and policy and behavior, but a lot of the research that comes out of health and that comes out of other areas of research is conceptual. We are sharing research to improve people's understanding, to help inform their decision-making, and it isn't always about use. So just an important distinction in sort of the terminology around knowledge translation. And if you unpack the term knowledge translation, which we're very fond of in Canada versus elsewhere in the world, it really is dissemination and implementation, two sides of the coin. So the two columns here highlighted in a sort of a goldy yellow. And again, it's about making information accessible and understandable so that we can benefit a range of people. And the emphasis largely is not just people in academia, but people outside of academia. So who are the knowledge users and the people who might like to know about our research evidence? And we do diffusion, but really more targeted dissemination. So sharing evidence with people, making it accessible, making it understandable. And then sometimes we have evidence that does lend itself to instrumental use, and we look to the science of implementation to inform that. And it's important to understand that the processes and strategies for dissemination are different than the processes and strategies for implementation. So I'm guess a bit of a maverick sometimes, but I'm a big proponent of changing our terminology so that we talk about dissemination and implementation rather than KT, because I think it's just more clear. And this is in fact the terminology they use in the United States and elsewhere. So In 2016, Vivek Wadhwa, who's a distinguished fellow and a professor at Carnegie Mellon University School of Engineering, declared that medicine will advance more in the next 10 years than it did in the last 100. And he went on to explain that we already wear devices like Fitbit and Apple Watch that monitor our physical activities and our sleep cycles and stress and energy levels. And we upload these data to servers via our smartphones. And our smartphones contain countless applications that keep track of our vitals and gauge our emotional and psychological states. He goes on to talk about how the sequencing of the human genome, which was completed in 2001, at a cost of about $3 billion, would be possible today for about $1,000, with costs falling so fast that by 2022, genome sequencing might be cheaper than a blood test. Now that it's been mapped into bits that computers can process, the genome has become an information technology. With increasingly large sample sizes and tools such as IBM's AI system, Watson, scientists are gaining an understanding of how our genes affect our health, how the environment, the food we eat, the medicines we take affect the complex interplay between our genes and our organisms. So within a few years, our genome, our microbiome, behavior, and environment will all be mapped and measured. And prescriptive medicine systems, precision medicine, based on artificial intelligence will help us feel better and live longer. Or will it? And that's the question. The vision of what we can accomplish, I think, is really compelling, but it's not going to happen automatically. It's not a make it so proposition. In order for those discoveries to impact health and well-being, they will have to be effectively implemented in our practice environments, whatever those practice environments are, in the community, in policies, and this will require efforts that are deliberate. Implementation must be explicit, intentional, and systematic. Our new discoveries will be groundbreaking for sure, but we will need to ask ourselves if these discoveries will have an impact beyond our CVs, our labs, and the walls of our research institutions. It might surprise you to learn that between 30 and 70% of health discoveries fail to be effectively implemented in a healthcare environment, and consequently, they never reach their intended potential. Research suggests that about 1/3 of new initiatives succeed. So that's a tremendous amount of research waste. The typical approach to changing practice will be familiar to many of you who are on the call today. And that approach is often referred to as a train and hope approach. In other words, we identify an evidence-based practice, we rally the troops to train them, and then we send them back to work with the belief that implementation will occur and they will change their practice without any further support. In practice, however, this rarely happens, and as is evidenced by several papers I've identified here. While improving practitioner knowledge about evidence-based practices is indeed part of the equation, it does nothing to prepare the organizational conditions needed for practice change. For this to occur, we need to organize and deliver supports much earlier in the game and work with implementing organizations to set the stage long before any training is conducted. Many years ago, Don Berwick wrote that failure to use available science is costly and harmful, leading to overuse of unhelpful care, underuse of effective care, and errors in execution. Practice change occurs at the individual level, the organizational level, the system level, all working in harmony to ensure we reach our postcard destination, whatever that might be. Key factors come into play, like relative advantage. How much better is an intervention than the practice that came before it? How compatible is that intervention with a person or a group or an organization's values, experiences, or needs? How complex is the new intervention to use or implement? Can you experiment with the innovation on a limited basis? Does it offer an opportunity for trialability? Can you observe the results of the innovations or that intervention in other settings. Interventions that do not have clearly visible results are adopted at slower rates than interventions with obvious results. Healthcare researchers produce copious research evidence on the effectiveness of new treatments and methods for care for patients that, if successfully implemented in practice, can potentially save or improve the quality of patients' lives. But not sharing leads to not implementing, and both amount to a lot of wasted investment. Globally, we spend $200 billion per year on health and medical research, and 85% of it is avoidably wasted. This translates to an annual waste of about $170 billion. So people don't get the best care as a result, and they can't find the information they need to make important decisions. So why are we missing the target? Why are we doing so poorly at implementation? The first problem is awareness. People don't know certain evidence exists, and we don't do a good job of sharing what we know in ways that people want. So this is the dissemination part of the equation. You need to get your work out there in a way that people can find, that they can understand, that they can be interested in, and that resonates for them, whoever they may be. Comprehension of what to do with the new intervention is often poor. When we do share it and they do access it, it's not usually shared with an intention to guide users who will benefit from it. So we put a lot of research evidence out there, we disseminate, without any instructions about how people might benefit from it or how they might implement it in their setting. The relevance of our research evidence can also be problematic. The research that does exist doesn't always answer the problems faced by decision makers or knowledge users, and so there's that disconnect. Implementing organizations are often not ready, and there's variable awareness and tension for change and multiple barriers for change that need to be addressed. So really, behavior change is difficult to achieve. It's time-consuming, it's expensive, and we are not using the science of implementation to support that implementation process, which is really curious because we're all about the evidence for the intervention, and we don't pay an awful lot of attention to the evidence on the implementation science side of things. So ironically, as I said, we fail to be evidence-based in our approach to applying the evidence. We don't use the science of implementation to guide the use and the application of scientific discoveries. So effective implementation requires us to be really explicit in asking whether people will know how to apply our discoveries and what their context is. This is not necessarily intuitive. We have to lay the path and lead them to success. You have to give knowledge users a runway that's illuminated, breadcrumbs, whatever analogy you want. You have to give people a recipe, a step-by-step process that they can follow. So our work as researchers doesn't end with the discovery. We have a responsibility to shepherd that innovation beyond the lab and beyond our hospital, our research institutions, and our organizations. The second objective for my talk today is to introduce you to implementation science as a way of addressing the issues that I've just presented. Quite simply, emerging around 2004, 2006 or so as a formal scientific pursuit, implementation science is a study of methods and strategies that facilitate the uptake of evidence-based practices, interventions, innovations of all kinds, and research into regular use. Somewhere, could be a village, could be an organization, could be a school, could be a clinic. And it's not necessarily dedicated to the health scenario. So you can think of implementation across other disciplines and other fields. Implementation science is linked to implementation practice. Science of implementation is our way of trying to study ways that improve outcomes for those being served. So implementation scientists look at and work closely with communities, and we really try and figure out what are the methods, what are the processes, what are the measures, how do we shape the approach, and what does that look like for different communities or different implementation environments. Implementation practice is the application of that evidence emerging from the science by people who are in implementing organizations or have a role to play in taking that evidence from the intervention and also from the implementation side and putting that on the ground to facilitate the implementation. Fundamentally, implementation of any type of intervention involves two sets of evidence. So if you think about, I'm just going to go with, I don't know, Crohn's disease, just because Eric's on the call. So we have the evidence about what is effective. In treatment, we have evidence about the etiology, et cetera, et cetera. That's one branch of evidence. But then we have evidence that comes into that from implementation science. So it's two sets of evidence about two sets of methods, two sets of procedures, two types of analyses, two types of outcomes, and they are integrated together in your implementation effort. So fundamentally, your mind starts to explode a little bit, because now not only do you have to pay attention to the science behind your intervention and the methods for studying that intervention, now you're also having to keep in front of mind the science of implementation and the methods, procedures, and so on that are related to the implementation endeavor. And what we're really interested in here is making sure that these interventions that we develop, that we prove to be good interventions, useful interventions, can actually be put on the ground. And what does that require? That requires obviously effective innovations or interventions, effective implementation, and an enabling context. And as you can see, because this is multiplicative, if any of those three elements are non-existent, you get a zero. So you don't get the outcome that you're looking for. So any component is weak, then you don't achieve your intended outcome. And so it means paying attention to all three of those elements. We use a lot of implementation theory that has evolved over the last 15 or so years. And just to point out, that implementation theory has evolved over time. And there are different sorts of theories, models, and frameworks that inform different aspects of implementation. One of the curious but common things I see often in people's implementation proposals is they pick one theory, model, or framework, which is might make sense to some extent, but usually leaves out other key aspects of the implementation endeavor. And so if you are mounting an implementation endeavor, you need to pay attention to process models, determinant frameworks that identify the factors that might be barriers or facilitators. And you probably also need an evaluation framework to look at your implementation outcomes. So most implementation endeavors that have a research component to them will have multiple theories, models, or frameworks that inform them, that cover off these different aspects of implementation. So I want to give you a bit of an offhand example and get you to think about IKEA for a moment. And the reason I do this is because this is a really interesting counterpoint to what we do in research. So ponder this for a moment. When you think about IKEA, right? IKEA is a really good example of how other sectors deal with evidence and how they disseminate it and how they think about how people will use it. So we're talking about evidence, they're talking about furniture, but I'm using them as sort of comparable in this example. And we all know a common experience for many of us in Canada is purchasing furniture that requires assembly. And I would bet you that everybody on this call has been in an IKEA, has bought something from IKEA. And so we all have this, experience. We put the time aside, we visit the store, we walk through this huge warehouse, we find our product, we get it to the cash, we get it in the car, we get it home. So there's a lot of effort going on here. And once you get your product home, it requires assembly, right? It comes in a flat box. And imagine for a moment that you open the box, you start to pull out all of the pieces for assembly, and the instructions are missing. Well, you're undeterred somewhat because you're super confident that you have the skills to assemble it based on your motivation and your competencies. So you give it a go and you start, and then you realize that there are screws missing, the Allen key isn't there, and you experience frustration and annoyance and exasperation, et cetera, et cetera. So the reason I tell this story is I want to suggest to you that when we develop evidence-based interventions without full consideration, so that's the instructions, the support, the coaching, regarding how they will be used, we're setting users up for this very type of experience and failure, right? We are saying, hey, great product, here you go, here's the evidence-based intervention, but we're not giving them any other guidance, typically, on how they need to apply that. Now, IKEA would never do that, right? It's a different kind of model. It's a business model. They would never make money. They would never build furniture, test it to ensure quality, and then store it in a warehouse where nobody could find it. Nor would they set up the purchase without the necessary supports in consideration of the users and their experience and their preferences and their prior knowledge and their demographic characteristics. And yet I think this is precisely what we're doing when we build interventions without implementation instructions and supports. So doing what we're doing this isn't serving the needs of those for whom these interventions were developed in the first place. Just something to ponder. So feasible methods to inform effective and sustainable implementation of evidence in practice requires knowledge about which factors are implicated in successful implementation. My program of research has conducted a couple of studies to explore these factors in the context of Canadian child and youth mental health service provider organizations. And before I get to that, I just want to share with you another sort of work example from my own work life over the last 20 years. Back in 1999-2000, just before I joined SickKids, I took on the lead for an outcome measurement initiative in the province of Ontario for the children's mental health sector. So this was predominantly community-based mental health organizations that were being mandated by the Ontario government at the time to measure outcomes for kids who were receiving mental health services in community-based settings, mostly community-based settings. They were funded by that particular ministry. And work was done to identify the tools that we would use and so on. And our team at SickKids took on the leadership of this implementation. I don't even think we knew about the term implementation when we took this on in 2000. This is before the birth of implementation science. And essentially, they gave us a list of 120 community mental health organizations in Ontario across the whole province and said, here you go. Here's the measure we want you to use. We want the clinicians to use as a clinician-rated global level of functioning measure called the Child and Adolescent Functional Assessment Scale, or the CAFAS for short. And go ahead and train them up, because we want the data. We want to know how kids are doing as a result of the services that they're receiving. So in 2000, the year 2000, we did what we could do. We hired trainers. We figured out what the training would look like. So first mistake, we went straight to training. We developed with the developer of the CAFAS a system for making sure there was inter-rater reliability with the clinicians to a gold standard. And we had a 2-day training, and off they went to all of these various regions of Ontario to train people up. And so the model in the day was you pick your evidence-based practice. For us, it was the CAFAS. You train the people up and you send them back to their organizations, and they're going to do the new thing. Well, lo and behold, they don't do the new thing. And we didn't have a better model. There was no illuminated pathway for us on how to really, from an evidence-based approach, support organizational change. We had our heads in training. Oh, you just have to train the clinician and everything will fall into place. Couldn't be further from the truth. So needless to say, as we got into this process, we actually ran this endeavor for 15 years. So we did get better and we did learn an awful lot. But this is the reality of the implementation journey, where you really have to prepare for the journey before you train anybody. We didn't know that back in the year 2000. And you also have to think about sustainability. So we had a good run. The province of Ontario supported this outcome measurement initiative from 2000 to 2015. And then, like everything else, processes changed, people changed, ministries changed, government changed, and so on, and they took a different approach. But we learned a heck of a lot about how to implement an assistant of care from this particular endeavor. So what I want to share with you is sort of a compilation of what I've learned over time, but also what the science tells us. And this is the distillation of the core components of implementation. I'm just going to check my time. And this emerged because I was invited probably 2017, I think it was, to lead a group of people out in Alberta on the basics of implementation. And these were folks, not academics, but who were working to support child and family health, child and family well-being in the community. And my task was to think about all of the science and implementation and give them a workshop that they would understand, that would hold their attention, and that would help them in understanding what they might need to do differently if they were to implement in their community-based organizations. So I took a stab at distilling and synthesizing the field of implementation into these 5 core components, as you can see them listed here: implementation team, process, factors, strategies, and outcomes. And I maintain that if you can pay attention to these 5 core components, you can do implementation in an evidence-based manner that is explicit, intentional, and structured. So that's where I've been putting my energies these days, and I'll tell you what that has culminated in and where that's headed a little bit later. So as I took this framework of core components out to Alberta with my colleague Jackie Brown at the time to do this workshop, I also thought, okay, I need a way that's going to make this less abstract for people to understand. So simplifying it into 5 core components is a good strategy, but how can I tell a story that helps people understand how these core components come together? And here's where I came up with the concept of the implementation kitchen. So not unlike my IKEA analogy, I have a kitchen analogy, which somehow I always tend to refer to cooking and recipes and so on, but it works really well when you talk about implementation. So think about cooking, and this is something that everybody has done, right? Everybody on the call, you've all cooked something. And if you break it down and you think about cooking, you know that you need an environment, a kitchen of some kind. But that kitchen could be in a home, it could be in a school or an industrial setting, it could be a campfire. So remember, context is coming into play here. So you need a kitchen, you need the right tools, whatever tools you're going to need to cook this recipe. You need a cook or cooks with the right skills. You need a recipe, whether it's written down or in your head, passed down through generations. You are following a step-by-step process that is known to you. You have to make sure you have the right ingredients that you're going to need in this recipe, and you know it needs some basic knowledge of the chemistry of how those ingredients mix and come together. We often adapt our recipes. It's a human nature thing. So there's adaptation to the recipes, but we also know that we could go rogue with that adaptation and really mess with what we're trying to cook. So adaptation has some leeway, but we need to be careful. And then there's evaluation of our cooking, and that can be evaluation of taste or look or nutritive content or cost, etc. Implementation and how those core components come together is much the same as cooking. So you need to think about what's the setting in which I'm going to implement this intervention or cook this recipe, right? So what's that setting? Is that setting receptive? Do I have an implementation team with the right set of skills? What is my recipe or my step-by-step implementation process? What are the factors that I need to be mindful of? Anybody who's made their own pizza dough knows that your pizza dough turns out one way when it's 35 degrees outside and super hot, and it comes out differently when it's really cold outside, right? So things in our environment, and I'll talk about that in a moment, really have an impact on our implementation process. We have to think about adaptation as we deliver that intervention. So it's the difference between adhering to the core components of the intervention with fidelity or going rogue and not realizing that you really aren't delivering the intervention that you thought you were delivering. And then there's evaluation of outcomes. And when we're talking about interventions and putting them on the ground, we're obviously talking about clinical outcomes. We might be talking about service or system outcomes, but we're also talking about implementation outcomes. So these core components, my core components of implementation science and practice, are these 5 things. And they come pieced together somewhat like a cooking experience. So I'm going to tell you a little bit about each of these core components, just at a high level. So first, let's just look at implementation team. So implementation teams, and it's really curious, one of the things that my implementation colleague, Jackie Brown, and I have been doing for the last 2 years is we're supporting implementation for 8 research teams that are funded out of the Kids Brain Health Network to implement their funded interventions into community organizations, and we're coaching them on implementation. And what's been really interesting is when you have a research-initiated implementation activity, researchers have a really hard time, I can say this because I'm a researcher, they have a really hard time with thinking about who is the implementation team. And it doesn't matter how many times we tell them it is not you, the researcher, it's still hard for them to digest that. So implementation teams are the people in the implementing organizations, not the researchers who might be studying it or funding it or in some way, shape, or form leading it, but it's the people in the implementing organizations. So they can be very different types of teams. You may include the developer of the intervention or the purveyor of the intervention or someone who's responsible for training initially. You might also include other intermediary support organizations. But essentially, it is a core group in the implementing organization that's going to take on the active tasks of everything that needs to happen around putting that intervention on the ground. It's usually about 4 or 5 people on a site, led by somebody who is in that organization, not somebody from the outside. And the reason this is super important is that you want the implementing organization to really own the new intervention. If somebody comes from the outside and does something to your team and then leaves, that's a bit of a train and hope dynamic, which I've already introduced. What you want is for the people who are taking on the practice change to own and guide and dictate what that change is going to look like, because it's the people in the implementing organization who understand workflow and process and how things happen and can come up with strategies for mitigating barriers, et cetera, and think through how their workflow might need to change. The second component, core component of implementation is process. And in process, we're really here talking about the recipe. And I usually refer to two main well-known process models in implementation. And I take elements of both in my research and practice work. And these are listed here for you. And one of those models of process is the active implementation frameworks, and they have different components, and I'm not going to go into to do too deep a dive here because it starts to be too much information, but suffice it to say that the active implementation frameworks, which is a process framework, so think recipe and steps, gives you an idea of what you need to do in the process of implementation at different stages along the way. So they were the first to come up with this notion of a stage or a phase of implementation. And that's really helpful procedurally. And if you think about cooking and you're baking a cake, you need to do what do you have in your kitchen? Then go get the groceries and come back. And now you're making the batter. That's the next phase. And then you're baking. That's the next phase, the icing, the next phase. Understanding that there are these phases in your work ahead of you helps you structure your activities and keep what you're doing top of mind. So that stage concept is really important. The folks at the National Implementation Research Network also identified this notion of an implementation driver. So what are the levers that help support change for any implementation endeavor? And they identify them, and they've developed tools to help people have conversations about these drivers in the implementing organizations. They came up with the notion of implementation team, and you can have a leadership implementation team and an operational implementation team that really do much of the work. And they've developed some really interesting usable innovations that help you have key important conversations about process within the implementing organization. And these are all available on their website. So I refer you there for more information. This is what the stages looks like. And I show this to you, not so that you can hold on to what the stages are called, but really to show you the important point I made earlier in my talk, which is look where training is. Training is not in box number 1, which is where, when we did the CAFIS initiative, we put it. We just jumped straight into training, ran around the province, training people, not realizing that just training individuals to do something different without paying attention to setting the context and the organizational conditions for supporting that training and supporting that individual being able to deliver that was not going to be super helpful. So what first has to happen is figuring out what the needs of the organization are, what's available out there to meet those needs. Does it fit? Is it feasible? Who do you need to engage? What kinds of decisions need to be made? And then moving to figuring out what implementation supports are needed, what's going to need to change here in this organization in order to put this intervention on the ground. What has to change in terms of workflow or process or hiring or people or space, all those things. And then who are we training? How are we deciding who we're training? How are we doing training in a way that is sustainable over the long term? And then moving on to, usually it's stage 3 of implementation, where you go live with your intervention and you initiate that new intervention and you do some evaluation cycles to see how it's going and you iterate moving forward. So you can see this is an entirely different approach than most of us take. Most of us are a train and hope type of model. The quality implementation framework lays out pretty much the same thing, but it's just another way to show you how much activity happens in planning and preparing for implementation prior to any active delivery, prior to any training. And I think that's a really, if you can only take away one thing from this talk, it's, can't rush to training, need to do a whole bunch of preparation before we get there. And they go further and break down a recipe, as it were, of 14 critical steps or in the recipe or the implementation process that one would need to follow to take an evidence-based approach. When we talk about factors, we're talking about all of those things in the environment that could mess with what we're trying to do. So these are barriers, these are facilitators, and the one determinant framework that I use very much, that is also highly published in the literature and well validated, is the Consolidated Framework for Implementation Research, or the CFIR, we call it, CFIR. And what's interesting about the CFIR is it was developed kind of as a synthesis of all of the other determinant frameworks that were out there and the empirical work on factors and barriers and facilitators. And they identified 5 big buckets of factors that that are really important for you to think about as you plan your implementation. Remember, this is the journey of my CAFIS journey in terms of implementation, not a straight line. It makes, the way I talk about implementation with core components and process and recipe makes it sound very linear. In actuality, it's not that linear. It's, 2 steps forward, 3 steps back, and then over to the side, and then forward again. But the factors that are going on around your implementation process include factors related to who's delivering, or the practitioner, factors related to the innovation or the intervention itself, factors related to your organizational context or your school context or whatever your inner context is, factors in the system at large, and then factors related to your process. And the CFIR actually breaks down like this, another wave of too much information. But essentially, when you're planning out your process, you need to also keep in mind that all of these factors are empirically associated with effective implementation. So how you engage your opinion leaders, how you plan for implementation, how you execute that implementation, whether you give people time to reflect and evaluate. Whether implementers perceive that this is a good intervention for their setting, that there's relative advantage to actually changing what they've done for the last 20 or 30 years, that there is some license to adapt, not the core components of the intervention, but who or how those core components are delivered in order to accommodate the context that they're in. That it's not complex, that it's cost, it's not prohibitive in a cost way. They need to think about their patients, external policies and incentives that might support or hinder the implementation of this endeavor, and so on. So as you think through the steps, these are sort of the, not quite the ingredients, but all of the things going on in your environment that you need to be thinking through that may be supportive or not supportive. And when you identify a barrier amongst all of these factors, that sets you up for the next core component, which is to think about strategies. Strategies help you mitigate the barriers. And the implementation strategy work, and to here I credit Byron Powell and many of our colleagues in the United States, doing syntheses of the research on implementation strategies in Canada. We might think of them as KT strategies, but they're implementation strategies, identifying 73 different strategies that address different types of barriers, and that can be grouped, as you see here, as different types of strategies. And so you pick your strategies based on what you need to address. And then the last element in my core components framework are implementation outcomes. Oh, and I probably didn't link this up, so I'll have to dig it out for you in a moment. But implementation outcomes are the outcomes of your implementation process. And this is also another one that the researchers I work with often have a difficulty wrapping their head around because they're so focused on their clinical intervention. But implementation outcomes really are get at the issue of, was your implementation effective? Did you conduct your implementation recipe, process, whatever terminology you want to use, in an explicit, intentional, and systematic manner? And the reason we ask about implementation outcomes is that it's not sufficient for a treatment to have been demonstrated to be effective. because that treatment's not going to be effective if it's not implemented well. And implementation outcomes are really necessary preconditions for understanding what happened clinically as a result of that intervention. So we have all probably clinically seen instances where we know an intervention is effective, but it might be effective at SickKids and it goes somewhere else and not so much. And it's not because the intervention failed, it's oftentimes because the implementation failed. And that's why using the science to make sure we conduct that implementation explicitly and intentionally and systematically enables us at the end of the day to determine whether an intervention is faulty in terms of itself or in how it was deployed. And I had a little video example of what that might look like in the real world, but I'm short of time, so I'm just going to continue. So what do we mean by implementation outcomes? Well, we usually look at Enola Proctor's work here out of the US, where she identified 8 different types of implementation outcomes. Now, this doesn't mean you need to pay attention to all 8, but here they are. And the other thing to think about in reviewing these 8 implementation outcomes is that you will be evaluating some of the outcomes early on in the first and second phase of implementation, not necessarily at the end of implementation. So for instance, early on as you're exploring fit and feasibility and what the implementing organization wants to do, you might be looking at things like, to what extent do the implementers see this intervention as acceptable, right? Are they intending to adopt it? Do they see it as appropriate for their setting or for the type of provider they are or for the sort of consumer or patient that's receiving it? So appropriateness and acceptability are similar but different. To what extent is the new intervention or treatment feasible? Can it be feasibly used or carried out in that particular agency or setting? What about implementation cost? And I know that we often think of that as a completely separate bucket informed by health economics, but it's really an implementation outcome to the extent that you want to be paying attention to what's the added cost of implementing the intervention and what's the cost comparatively to what you've done before to delivering this new intervention versus something that you used to do before. So that cost benefit or cost effectiveness analysis. So cost is also an implementation outcome. And then these next 3 are really super important. And fidelity. So fidelity is adherence and competence, the degree to which your intervention was delivered the way it was intended to be delivered. And I mean, in mental health, we're often not really adhering. Are you really delivering CBT? Are you really delivering that intervention that you thought you were delivering? Because remember, we like to make adaptations, and adaptations are a necessary component for feasibility, for utility, for relative advantage, because you have to fit an intervention into your particular setting and context. But you can't mess with the core components of that intervention. If there are 5 things you need to do to deliver cognitive behavior therapy, you have to do those 5. Otherwise, it's not cognitive behavior therapy. But what you can adapt is who delivers, how do they deliver, and what does that look like on the ground in that particular organization. So fidelity is key. Penetration is another implementation outcome. How many patients who could have received that intervention got it? Or how many clinicians who could have delivered that intervention actually deliver it. And then this notion of sustainability, which we start to think about in phase 1 of implementation, which is, well, how are we training? Who are we training? How are we maintaining this? Eventually, implementation is going to hand off to quality assurance and program evaluation that is sort of ongoing and maybe more established. But you have to think about how all of these activities are going to be sustainable over time. And this is particularly important for researchers working with implementing organizations in the community when the initiating context for the implementation is a research grant. So the research grant is going to pay for a lot of what's involved in implementing X intervention in Y setting. but the researchers are going to disappear at some point. That money is going to be finished at another point. And the people who are the implementing organization are going to be left holding the bag, which means they have to own it, they have to know how to run it, it has to be in their intervention, and they have to know how to sustain training over time and how to pay for it over time. It needs to actually become seamlessly part of their organization. So very quickly, a couple of other things you might want to know about hybrid effectiveness designs. Over time, we've learned that it's not super efficient to section out the efficiency and effectiveness studies clinically from the implementation studies that happen later. And so Jeff Curran and his colleagues in the United States slowly started to conceptualize and write about this hybrid effectiveness design where you're actually merging clinical and implementation effectiveness questions together at the same time, which makes things move along a little bit more quickly and more efficient. And you can look this up later if you're interested. He's written about 3 types of hybrid designs. The first, where you're still really invested in testing the clinical intervention, but you're starting to have an opportunity as you develop that intervention to start asking some questions. Remember the IKEA example of who's going to put this on the ground? How are they going to use it? What's that going to look like? And you should be thinking about that as you're still developing your intervention. And then you move through to type 3, where, you know what, you might have an intervention that has tons of clinical data about its effectiveness. It's not even a question anymore. This intervention works. But what you really want to know is things about how to improve the implementation of that intervention in different contexts. And type 2 is a more balanced. So that's just the notion of hybrid designs to be looking at as you do some of this work. And the last thing I want to introduce to you were the standards that we developed a couple of years ago now. I was leading this effort in Canada, and somehow through social media or some other means ran into Hilary Pinnock, who was leading this effort, similar type of grant out of Glasgow, and we Edinburgh actually, and we merged our projects and we came up with the standards for reporting implementation studies. And as you know, standards for reporting are really useful as you're developing your methodology. So I encourage you, those of you who are doing implementation research, to go and look at those standards, and particularly the checklist. And remember, as I pointed out to you in the beginning of my talk, implementation work is this melding of clinical evidence and implementation evidence, and clinical methods and implementation methods. And this checklist and the standards allow you to be explicit and intentional and structured in both of those pathways as you work through your research. And so I think it's super helpful as a guide, but also as a reporting guideline. So I guess my concluding statement is, as I pointed out in the IKEA example, evidence-based practices, I think, are not truly evidence-based practices unless we can articulate and demonstrate how they can be implemented. You know, there's been a shift in government funding that now forces researchers to validate the results of their project before they've even started it. I think scientists should be accountable where work is funded by the taxpayer, and think about, you know, these kinds of questions of what kind of impact are they going to have? How are people going to use this research evidence? So unless we focus on how groundbreaking interventions that we're all working on are implemented, discoveries that we develop, it should probably be 2021 now, will not be routinely used in clinical practice until 2037, 17 years from today. I don't think we can wait that long. So in conclusion, where to learn more about dissemination and implementation, we have a range of different workshops. Most recently, the planning for implementation practice that we run out of SickKids, and because of COVID pandemic, we are running all of these workshops virtually. It's been challenging, but it's also very doable. Some other tools and resources for dissemination available again through the SickKids Learning Institute. This is our new planning for implementation practice workshop and the learning objectives, where we are taking teams, implementation teams, through a planning process based on the core components, and using my new resource called the implementation game, which is a manifestation and a gamification of those 5 core implementation components that I showed you. Also a little plug for our new monograph in collaboration with the American Institutes of Research, and my contact information. And down to the wire, I think it's probably a full hour, but that's what I wanted to share with you. I hope you came away with a sense of how dissemination and implementation are different. So my main messages would be processes and strategies for dissemination are different than processes and strategies for implementation. The importance of really paying attention to the process of implementation, not running to training without thinking about laying the foundations organizationally, following the core components, and using some of the tools either that I've developed in my team or developed elsewhere to help you actually think through the practicalities of negotiating an implementation endeavor. And I want to thank Linda for inviting me for today, and Eric as well, who I saw had to run. We maybe have time for maybe 1 or 2 questions, Linda, if there are any.
I completely agree. And I don't know if you have time, again, to maybe a few additional minutes if some extra questions come on. But if anyone does have a question, if you could either maybe raise your hand and unmute or type it in through the chat, that would be great.
I've stunned you all with way too much information, I think, so on a Friday.
And I have to say, even in terms of CCHCSP as a program, I found this presentation very valuable, especially as we're preparing to reapply to our own HRTP grant that's coming out here at CIHR. So thank you very much.
Okay,
so it looks like one question has come in from Olivia. I was wondering if you could speak to how you prepare implementation teams for the amount of time invested in conducting appropriate implementations.
Right. So I'm sensing Olivia probably has her own lived experience here, and she's thinking about certain teams and so on. I think you all have to think about the opportunity cost of not taking an evidence-based implementation approach. So you think about the alternative to just kind of saying, okay, let's gather everybody together and send them to training, and then we'll send them all back and they can sink or swim. It's not going to be successful. You aren't going to get to where you're going most of the time. And there's a cost to all of that. So the other thing is, in most situations, and I'll talk about the research context in a moment, because I think that's particularly interesting, but organizations that are adopting new interventions want to adopt new interventions. That's kind of the best case scenario, right? You're not going to force somebody to change their practice. So an implementing organization wants to know what's the intervention, which we spent a lot of time in developing what's called a practice profile, which is getting either the researchers who develop the intervention, mostly it's the researchers, to explicitly describe what the core components of their intervention are. Super challenging. And, they think they've got this intervention, it's ready to go, but then they have a hard time breaking down what are the non-negotiables that people have to do to deliver that intervention. So we spent a lot of time with that, making sure that implementing organizations know what the intervention is, who has to do what do they have to do. Much of the time, at least in sort of what I see, the initiating context is a research grant. So you got researchers over here and you have organizations that want the intervention, and it's a bit of a forced marriage, right? You're trying to make sure the researchers are not too bossy, because they are not the ones making the decisions on the ground. They're in charge of their research procedures, and the implementing organization is in charge of everything else. And I think it's about building a business case for that organization about you want this evidence-based intervention because it's evidence-based. It's been demonstrated to be really effective for youth with serious depression. Well, why wouldn't you use evidence to help you implement it? It just seems counter. And I think people need to process that and think about it a little bit and say, okay, well, that makes sense. The other thing that implementing organizations want to know is, how complex is this going to be? How much of a headache is this going to be? How much time is it going to take? And so on and so forth. But they're going to take time. In a haphazard approach to implementation is going to take them way more time and be less efficient. So this is the difference from saying, look, you're going to drive to Montreal or Chibougamau from Toronto, and I'm not giving you a map. Go for it, right? Or giving somebody a map, telling them where they're going to stop along the way, where there's food, where they can sleep, where they can, use the facilities and so on. What you're doing is you're really giving them a breadcrumb trip map of what they have to do when. And there are external supports that might be available to them from the research team to get them going, or there are implementation consultants in the communities. And sometimes evidence-based interventions have their own implementation supports built in as well, at least around the training and evaluation and getting people started in a process that's supported by implementation science. So Olivia, I think it's a little bit of you got to know the people on the ground who are implementing. What discussions should you be having with them? What argument and business case is going to work for them? Probably the hardest to convince sometimes are the governments, who just kind of want you to snap your fingers and make it so, and doesn't happen that easily, right? And I think it's also important for the funders to recognize that implementation is an evidence-based process, right? It's going to take a certain amount of time. It might not fit in the granting time. You might not get to full implementation in 3 years, depending on the scope of what you're doing. So it's about educating people and sharing, disseminating this evidence, but also giving people skills and tools and resources that make it easy to do, or easier, simpler to do. So that's what I'm trying to do.
Thanks so much, Melanie. And I'm just looking at the chat and I don't see any more questions coming up. I do see a quick comment from Melissa just stating how this reminds her of the COVID-19 vaccine timeline between first and second doses. And I think that is quite true. So everybody is very thankful for you joining us, and given the time, I think it's a good time for us to end for the day. Thank you so much for joining us. I mean, what a fantastic presentation and a great deal of information. We've learned so much today. And with that, I'd also just like to remind everybody of our next session that will actually be taking place on Wednesday, February 24th from 1:30 to 2:30 p.m. We have Dr. Christine Chambers, Katie Burney, and Carrie Tiffin talking to us on how to build your brand. And that will be followed by the Friday, March session at 12 p.m. on quality and quantitative research that will be given by Stella Nung and Sandra Vander Kay and facilitated by Peter Cahill out of McMaster. So thanks everyone for joining us, and look forward to seeing all of you at our next session.
Happy long weekend, everybody. Stay safe, and thank you so much for your questions and for your time this afternoon. Wishing you all a very happy family day.
Thanks, Melanie.
Thanks so much, Melanie. Bye.